Welcome to Auxanö Medical Podcast, where you grow in your medical knowledge. I am your host, Dr. Julius Kwedhi, and with me is the always amazing and clinically sharp-minded Dr. Anastasia.
Hello, Julius. It's wonderful to be here. And we have a fantastic show lined up today for our listeners.
Yes, we do.
We're diving into a topic that was once the exclusive domain of, highly specialized centers, but is now becoming a more practical reality for many: complex aortic pathology.
That's right. Specifically, we're talking about aneurysms that are notoriously difficult to treat. We mean those nestled right up against the renal arteries. To help us demystify this, we are truly honored to have a giant in the field of vascular surgery with us, Professor King. Professor, thank you so much for joining us.
Thank you for having me, Julius and Anastasia. It's a pleasure to be here and discuss this fascinating evolution in aortic repair.
And before we dive into the technical aspects of our discussion, I'd like to share this week's wisdom nugget. It comes from the book of Proverbs, chapter 16, verse 3, which says, "Commit your work to the Lord, and your plans will be established." As clinicians, we spend so much of our time planning.
So much.
Right? Planning a diagnosis, planning a treatment, and in the case of today's topic, meticulously planning a complex surgical intervention. This verse reminds me that when our work is committed to a higher purpose, to the service and healing of others,
Yes.
our detailed plans find their truest and most solid foundation.
That's a beautiful thought to start with, Julius. Shifting gears, Professor King, let's begin with the fundamentals. When we, as clinicians, hear the term complex aortic aneurysm, what exactly should come to mind?
Right.
What separates these from a standard abdominal aortic aneurysm, or AAA?
That's the perfect place to start. A standard or infrarenal AAA has a healthy segment of aorta below the renal arteries.
Okay.
We call this a proximal neck. This neck is crucial.
It's where we anchor a standard angraft to seal off the aneurysm. An aneurysm becomes complex when that neck is compromised. We classify them as juxtarenal, where the aneurysm begins immediately below the renal arteries, leaving virtually no neck, or pararenal,
Right.
where the aneurysm sac itself involves the origins of the renal arteries. In these cases, a standard graft would cover or occlude these vital arteries, leading to kidney failure.
And that's where the challenge lies, preserving blood flow to the kidneys and often the other visceral vessels like the superior mesenteric artery,
Exactly.
while still excluding the aneurysm from circulation. Anastasia, from a diagnostic standpoint, what are we looking for?
That's a critical point, Julius. The majority of these patients are actually asymptomatic. The aneurysm is often an incidental finding on an imaging study done for another reason.
Right, an accident.
Exactly. Perhaps a CT scan for abdominal pain or a routine ultrasound. But once we suspect a complex AAA, high-resolution, thin-slice CT angiography is non-negotiable. It's not just for diagnosis.
That's key.
It's the blueprint for our entire intervention. We need to see the precise relationship of the aneurysm to the visceral vessels, measure diameters with sub-millimeter accuracy, and map out the anatomy for what comes next.
So this detailed blueprint leads us to the solution. Professor, how do we tackle an aneurysm with a hostile, short, or non-existent neck?
Yeah.
This is where fenestrated and branched EVAR come in. Can you break down these techniques for us?
Certainly. Both FEVAR and BEVAR are ingenious solutions to the same problem. With fenestrated EVR or FEVR, we use a custom-designed stent graft. Based on the patient's specific anatomy from their CTA, we create small holes or fenestrations in the graft material.
Wow.
These will precisely overlay the origins of the visceral arteries. Once the main graft is deployed, we work from inside it, guiding catheters through these fenestrations and placing smaller bridging stents into the renal or mesenteric arteries to ensure they remain patent.
And with branched EVR or BEVR?
Branched EVR is conceptually similar. Instead of just holes, the graft has actual branches, like small sleeves, extending from the main body.
Okay.
We navigate sheaths into these pre-made branches and then deploy our bridging stents from there. Think of it as creating a new, reinforced internal pipeline, complete with its own custom-built exits to supply the vital organs. The goal for both is the same.
Right. To extend our proximal ceiling zone into a healthier segment of aorta above the visceral arteries without sacrificing their blood flow. It's an incredible display of personalized medicine meeting surgical innovation. Professor, what are the device options?
Is this something that has to be custom ordered for every single patient?
For many elective cases, yes. The most well-known device in the U.S., the Cook Zenith Fenestrated, or ZFen, is a custom device. We perform a detailed 10-step planning process, measuring lengths, diameters, and clock face positions of the arteries. Wow! And we send that plan to the manufacturer. This can take several weeks. However, the field is evolving. For more urgent cases, or for certain anatomies, there are now off-the-shelf options available, particularly in Europe, like the T-branch multi-branch device.
Okay. And in true emergencies, some centers will even perform physician-modified endografts, or PMEGs, where the surgeon modifies a standard graft on the back table to suit the patient's anatomy.
With all these options, open surgery, FEVAR, BEVAR, how do we decide what's best for the patient?
Yeah, the big question. What do the guidelines say?
That's the million-dollar question. And the latest 2024 ESVS, the European Society for Vascular Surgery guidelines, give us a very clear framework. First, the threshold for elective repair is generally a diameter of 55 millimeters in men and 50 in women. For a patient who is at high risk for open surgery due to comorbidities,
Right.
FEBA EVAR is now considered the first-line therapy. For a healthier standard risk patient, it becomes a shared decision. We discuss the pros and cons of both open surgery and endovascular repair.
And what are those pros and cons, Professor?
Well, open surgery is still an excellent and durable option, but it involves large incision, suprarenal clamping, and a longer, more arduous recovery. Endovascular repair, on the other hand, is minimally invasive with a much faster recovery. The data is clear that technical success rates for fenestrated EVAR now exceeds 95%.
Incredible.
With very low perioperative mortality. The trade-off, and this is a key point for patient counseling, is the need for lifelong surveillance.
Okay. And a higher likelihood of requiring secondary interventions down the line compared to open repair.
That meticulous planning you mentioned earlier must be the cornerstone of that 95% success rate. Could you give our listeners, especially the trainees, a pearl from that planning process?
Absolutely. The single most important factor is creating a durable proximal seal. We aim for at least 2 centimeters of sealing zone in a healthy, parallel-walled aorta, often above the celiac artery. During planning, we use 3D software to create a center line of flow. From there, every measurement must be precise. The length from the top of the graft to the center of each visceral vessel, and crucially, its clock face position. Is the right renal artery at 9:15? Is the SMA at 12 o'clock? An error of a few millimeters can mean the difference between seamless cannulation and a real struggle in the operating room.
Incredible. And speaking of the operating room, what's a key tip for a resident when they're scrubbing in on their first FEVR case?
One common challenge is a misalignment between the fenestration and the target vessel. A very useful trick is to use a buddy catheter. You may be able to get a wire through the fenestration, but your sheath won't follow, so you can advance a second catheter wire system alongside the first to help guide the sheath or change the angle. Another pearl is wire selection. In the delicate renal arteries, we favor a softer J-tipped wire like a Rosen wire over a stiff Amplatz wire.
Which can cause dissection or perforation. And finally, always use intraoperative advanced imaging, like cone beam CT, before the patient leaves the table. It allows you to check for any stent compression or subtle endoleaks that need to be fixed right away. Professor, your experience is global. From your perspective, how do these approaches and guidelines like the ESVS compare to practices in other parts of the world? For instance, in Russia?
That's an insightful question. While specific device availability can vary, the fundamental principles are becoming universal. I've collaborated with colleagues in Russia and across Eastern Europe, and the trend is the same.
Okay. A strong drive towards minimally invasive solutions for complex vascular disease. The Russian national societies are very active, publishing their own consensus documents, which are heavily informed by the major international guidelines, like ESVS and AHA.
That's great.
The core techniques of meticulous planning with CTA, the principles of visceral vessel preservation, and the endovascular first approach for high-risk patients are globally accepted concepts. The language of aortic repair is becoming standardized, which is fantastic for both training and patient outcomes worldwide.
That's fantastic to hear. The convergence of best practices is a win for everyone.
Definitely.
Before we move to our final takeaways, I want to revisit our wisdom nugget from Proverbs 16:3. Commit your work to the Lord, and your plans will be established. Listening to Professor King describe the 10-step planning process, the sub-millimeter precision, the clock face positions, the careful selection of wires and stents, it is the very definition of committing our plans to excellence. This isn't just a job.
No.
It's a craft. It's a profound responsibility. And when that work is rooted in compassion for the person on the table, our plans to heal and restore are indeed established on the firmest ground.
A powerful connection, Julius. Professor King, on behalf of our entire audience, thank you for sharing your expertise. This has been an incredibly enlightening discussion.
The pleasure was all mine. Thank you.
Julius, let's wrap this up. What are the key take-home messages for our listeners?
I think there are three main points. First, complex juxtarenal and pararenal aneurysms are defined by a compromised proximal neck, making standard EVAR unsuitable. Second, fenestrated and branched EVAR are advanced, minimally invasive techniques that solve this problem by incorporating visceral vessels into the repair.
Right.
And third, and perhaps most importantly, the key to success is meticulous, painstaking preoperative planning based on high-quality CT angiography.
The battle is often won or lost before the patient even enters the operating room.
Excellent summary. And on that note of preparation and planning, we will close. Thank you all for joining us on the Auxanö Medical Podcast, where you grow in your medical knowledge.